Yeah, he's there. So he will be talking on point of care test to identify non-responders to anti-VEGF injections.
Thank you very much, and good afternoon. So I would be talking about a point of care test kit to identify non-responders to anti-VEGF. Currently, we know that if you inject multiple anti-VEGFs, then only you will know whether the patient is responding or not responding. And then if it is not responding to anti-VEGF, we may move to alternate treatment like steroids. So can I move to the next slide? Slides, please. Yeah. So we are the Proteomics and Molecular Medicine Study Group, which got funded from Government of India for this. And as our mentor says, you have to always innovate in order to touch 1 billion lives. We know that good, tight, metabolic control, laser, anti-VEGFs, and vitreous surgery are the mainstay for treatment, but we have different types of patients. One type of patients who respond quite well like this, and another type of patient who worsens despite treatment, the non-responders to anti-VEGF therapy, which is about 30%. And we will come to know about these non-responders only after about 4 or 5 injections. So the basic idea would be to find out them in the first injection itself. So you have to store the aqueous samples, and we have to differentiate between the responders and the non-responders. They are stored at minus 70 degrees. And first of all, we thought, whether the VEGF levels were very high in those non-responders, and that is why we looked at the ELISA VEGF levels, and we found out that there was 3 group of patients, one with very, very high VEGF levels of 2,500, which was behaving a little different. But the percentage of those patients were very, very minuscule, only 4%. And then we differentiated the responders and non-responders into 2. One would be, reduce more than 40% of the macular thickness in 4 months. If only 4 injections were required in 6 months, and if all the if patients with macular thickness normalized in 6 months. So these were the responders, and all these 3 were negative. They were called the non-responders. So we have the responders in the non-responder population, and then we looked at the VEGF levels as well as a lot of other cytokine levels. We found out very interestingly, we found out that the non-responders had multiple injections, and so the VEGF levels were actually very low. So the non-responders' VEGF levels are lower than the responders, which means that there is some other cytokines at play, and our next idea is to find out the other cytokines, so and the proteins which are different. So we did a 2-dimensional gel electrophoresis, and here we find out the differences, 5 proteins which are differently there in non-responders and responders. And then we moved into other cytokines with a multi-bead assay flow cytometry, and we looked at about 12 cytokines, and we found out that IL-6 was higher in non-responder, IL-8 was higher, IP-10 and MCP-1 were higher in the non-responders to anti-VEGF therapy. So that was published, and then the next idea was to actually correlate those non-responders to the OCT parameters, because finally OCT-based parameters will give us a non-invasive tool, and so these things were looked at, and we found out that IL-6 were higher in spongy edema, ISOS junction which was disrupted, and drill which was absent, and also IL-8 like that. And then the next thing was the development of a lateral flow kit which takes into account 2 things. One is the protein, which differentiates between the responders and non-responders, and number 2 is the cytokines which respond. So it's a sample pad in which we will write, we'll put it, and there is a conjugate pad where all the chemical reactions take place, and then on the nitrocellulose membrane we will find out whether the proteins are present or absent, or the cytokines are present or absent based on numbers. And so we developed 2 such kits prototypes, and one example I'm just showing you here. So this is this patient with very poor response, and we can sign that the proteins were very high in that particular leg. And here again the cytokines are much higher in this. So the validation is the next tool. So we have used these proteins, and it can pick up the inflammatory cases, and we can use this in 15 minutes. We'll come to know whether the patient is a responder or non-responder in the first injection itself. Thank you very much.
Very nice, Gopal. Very, very innovative. This is only for DME you're doing, is it?
This is a candidate disease, sir. Once we find out DME, similar, things can be extrapolated for retinal vein occlusion, branch retinal vein and central retinal vein occlusion, as well as for age-related macular degeneration. But AMD will have a separate set of cytokines and proteins. It will not be similar to diabetic retinopathy.
Right.
What is the specificity of this test and sensitivity?
Yeah. So when we looked at responders versus non-responders, to increase the sensitivity and specificity, we did not cut in the center. We took the best responders on this side and the worst responders on the other side, so that it could be more specific and sensitive. But as I said, this is a proof of concept. So once we move to validation with multi-centric study with multiple, maybe more than 200 patients, then only we will come to know the exact sensitivity and specificity.
What about the cost for each
Sir,
patient?
it depends on the number of users. Probably it can be costed at somewhere around 2,500 per test kit.
How many patients have you done like this?
About 80, sir.
80 only. Okay.
Okay. Thank you very much.